Aortic dissection. Definition: it's a tear in the inner wall of the aorta anthema, creating a false lumen for blood flow longitudinally along the media of the aorta, and is most often seen in men from 50 to 70 years old. Etiology: hypertension, Marfan syndrome, atherosclerosis, trauma during castration. Classification: we have three types: 1, 2, 3. Type 1, originating in the ascending aorta, propagating at least to the aortic arch. Type 2, originating and confined to the ascending aorta. Type 3, originating in descending aorta. Clinical picture: chest pain, the main symptom, acute onset, severe sharp tearing pain radiating to the back. The condition must be differentiated from other causes of acute chest pain, especially myocardial infarction, by the following criteria. Patients usually have no previous attacks of similar pain. The pain is usually of maximum intensity from the start, associated aortic regurg or unequal pulse. The use of anticoagulants or thrombolytic therapy in a patient with aortic dissection in one word is fatal. Hypertension: in most cases, hypotension may suggest aortic rupture. Aortic regurgitation: in more than 50% of the cases. Obstruction of the opening of the aortic branches depends on which artery is blocked. Coronary artery, coronary insufficiency. Subclavian artery, unequal pulse. Ischemic symptoms of brain, stroke and syncope. Ischemic symptoms of spinal cord, paraplegia. Mesenteric arteries, abdominal pain. Renal artery, renal failure. Rupture aneurysm into pericardium leading to cardiac tamponade. Sudden death in 40% of the cases. Investigations: X-ray, mediastinal widening, ECG, excluding other causes of acute chest pain, myocardial infarction, transesophageal echo, aortography. CT and MRI are the gold standard for final diagnosis. Treatment: controlled hypertension, beta blocker esmolol with nitroprusside. Surgical correction: we have prognosis without surgery is very poor, and aortic dissection in ascending aorta is surgical emergency. And then we have cardiomyopathy. Cardiac muscle disease in absence of known primary cardiac etiology, no hypertension, congenital, valvular, coronary, or pericardial diseases. Clinical manifestations: we have three main types: dilated, hypertrophic, and restrictive. Dilated or congestive cardiomyopathy, characterized by ventricular chamber dilatation, systolic dysfunction leading to congestive heart failure, or congestive cardiomyopathy. It is the most common type, affecting any age, any sex, but most oftenly in middle-aged men. Etiology: idiopathic, infection, viral, Coxsackie B, HIV, bacterial, immunological, SLE, iatrogenic, adriamycin, alcohol, cocaine, infiltration, amyloidosis, sarcoidosis, hemochromatosis, endocrinal, diabetes, and acromegaly. Neurological: Friedreich's ataxia, Duchenne myopathy, myasthenia atrophica. This is an important MCQ note. Clinical picture: congestive heart failure, left-sided heart failure, right-sided heart failure, arrhythmia, thromboembolism. Investigations: we have X-ray, ECG, echo show dilated heart, biopsy for amyloidosis or sarcoidosis. Treatment of heart failure: ACE inhibitor, beta blocker, diuretics, heart transplant in refractory cases. Treatment of arrhythmia, treatment of thromboembolism, anticoagulants. Then we have hypertrophic or obstructive cardiomyopathy. Asymmetrical ventricular hypertrophy, especially in the interventricular septum and left ventricle. This thickening of the myocardium leads to diastolic dysfunction due to myocardial stiffness, and this leads to obstruction in the left ventricle outflow tract, leading to subvalvular aortic stenosis. Hypertrophic cardiomyopathy, considered to be the most common cause of sudden death in young sportsmen. Then we have etiology: autosomal dominant disease, such as idiopathic hypertrophic subaortic stenosis, IHSS, or associated with Friedreich's ataxia. Clinical picture: diastolic dysfunction, pulmonary congestion, low cardiac output syndrome. Manifestations of aortic stenosis: angina, syncope, sudden death, usually associated with sports, most probably due to ventricular arrhythmia. General signs: jerky or bifid carotid pulse, giant A wave if there is right ventricular outflow tract obstruction. Cardiac examination: double apical impulse due to palpable atrial systole S4, paradoxical splitting of S2, no click as obstruction is subvalvular, not valvular. Left parasternal late ejection systolic murmur. Associated mitral regurg is common, leading to apical pansystolic murmur. The murmur of hypertrophic cardiac myopathy, contrary to valvular aortic stenosis, decreases by leg raising or squatting because of increased venous return, which fills the ventricle, so it decreases the obstruction. Investigations: X-ray, no cardiomegaly, or we have pulmonary congestion. ECG, left ventricular hypertrophy, deep wide Q wave arrhythmia. Echo, ventricular hypertrophy, mitral stenotic anterior motion. SAM. Treatment: amiodarone for arrhythmia, beta blockers, decreases contractility and outflow obstruction, as well as calcium channel blockers. Avoid digitalis and other inotropics because they will increase the outflow obstruction. Surgical resection of hypertrophied septum. Then we have restricted cardiomyopathy, characterized by restrictive diastolic ventricular filling with normal systolic function. It is the least common form of cardiomyopathy. Etiology: idiopathic endomyocardial fibrosis. Infiltration: amyloidosis, sarcoidosis, hemochromatosis. Clinical picture: similar to constrictive if left ventricle is involved. Systemic congestion, low cardiac output symptoms, and atrial fibrillation. Pulmonary congestion if left ventricle is involved. Cardiac signs: signs of right ventricular enlargement, late and mild. Murmur of mitral and tricuspid regurg due to involvement of papillary muscles by fibrosis. No pericardial knock. Investigations: X-ray, no or mild right ventricular enlargement, no calcification to differentiate it from constrictive pericarditis. ECG, low voltage. Echo, diastolic dysfunction. Endomyocardial biopsy is diagnostic. Treatment of the cause: hemochromatosis, symptomatic treatment of heart failure, arrhythmia, and thromboembolism. And finally, cardiac transplant in refractory cases. Pulmonary circulation, pulmonary hypertension, elevation of the pulmonary arterial pressure above 30 over 15 mm mercury, or mean pulmonary arterial pressure over 20. Etiology: we have primary pulmonary hypertension and secondary pulmonary hypertension. Primary is very rare, representing less than 1% of all cases. Etiology is unknown, more commonly in middle-aged females with repeated pregnancies due to repeated thromboembolism or pulmonary vasculitis. Secondary pulmonary hypertension: we have hyperdynamic, passive, vasoconstrictive or reactive, obstructive, and acute obstructive. Acute obstructive, biologic, massive pulmonary embolism. And then we have hyperdynamic pulmonary hypertension due to increased pulmonary arterial blood flow, and this occurs in hyperdynamic circulation and in congenital heart diseases such as ASD, PDA, VSD. Passive pulmonary hypertension due to pulmonary congestion, left-sided heart failure, and mitral valve disease. Vasoconstrictive or reactive pulmonary hypertension due to reflex vasoconstriction of pulmonary arteriole in response to long-standing pulmonary congestion, long-standing hyperdynamic pulmonary hypertension, or hypoxia due to COPD. Obstructive pulmonary hypertension, long-standing vasoconstrictive pulmonary hypertension leads to irreversible vasoconstriction of pulmonary arterioles. So this seems that there are stages. Hyperdynamic or passive pulmonary hypertension or congestion lead to vasoconstrictive pulmonary hypertension, leading to obstructive pulmonary hypertension. Clinical picture of the cause: right ventricular enlargement, right-sided heart failure, signs of pulmonary hypertension, giant A wave, which is not present in ASD. Cardiac: we have inspection, pulsation in the second left intercostal space, diastolic shock, palpable accentuated pulmonary component of S2, percussion, dullness in the second left intercostal space, auscultation, accentuated S2. We have S4, ejection click, ejection systolic murmur due to relative pulmonary stenosis or early diastolic murmur due to relative pulmonary regurg. Investigations: X-ray, right ventricular enlargement, dilated pulmonary artery. ECG, peaked P wave, P pulmonale. And then we have echo, detection for the cause, estimation of pulmonary artery pressure, right ventricular enlargement, and we can find this also in catheterization. Treatment of the cause, treatment of right-sided heart failure. Drugs: they are of limited benefit. ACE inhibitors, anticoagulants. Prostaglandin I2, potent systemic and pulmonary vasodilator. Calcium channel blockers, diuretics. Heart-lung transplantation is the chief therapeutic option. Then we have pulmonary embolism. Etiology: source of emboli, whether DVT, detached thrombi from right side of the heart, paradoxical embolism, or rare. Rare, we have fat, air, amniotic fluid embolism. Paradoxical embolism from the left side of the heart, if there is left to right shunt, such as VSD. Detached thrombi from right side of the heart, as infective endocarditis, atrial fibrillation, myocardial infarction. And finally, we have the commonest cause, DVT, deep venous thrombosis. Predisposing factors, Virchow triad, slow circulation, injury of endothelium, hypercoagulability. Risk factors, 6 O's, operative, especially pelvic and bone surgery, oncology, cancer stomach, leukemia, lymphoma, old age, obesity, oral contraceptive pills, others with 2C, congestive heart failure, and coagulation disorders, protein C and S deficiency. Sites for DVT, deep veins of the leg, particularly iliac, femoral, and popliteal veins. Clinical picture. Unfortunately, there are no clinical or laboratory findings which will confirm or exclude diagnosis of pulmonary embolism, so the clinical picture is not specific at all. It's a combination of clinical suspicion with appropriate use of diagnostic tools. Small-sized emboli, recurrent small pulmonary emboli resulting from occlusion of large number of pulmonary arterioles, leading to occlusion of large number of pulmonary arterioles, usually asymptomatic, but non-specific symptoms of tachypnea, dyspnea, tachycardia, or pleuritic chest pain may occur, may result in development of pulmonary hypertension or subacute cor pulmonale over years. Medium-sized emboli, pulmonary infarction, if occlusion involves less than 60% of vascular bed, clinical picture, dyspnea, cough and hemoptysis, pleuritic chest pain. Acute massive pulmonary embolism, if occlusion of more than 60% of vascular bed, we have acute dyspnea, acute chest pain similar to anginal pain due to reflex coronary spasm and distension of pulmonary artery, sudden appearance of pulmonary hypertension, acute right-sided heart failure, shock, obstructive shock. There is marked decrease in blood flow to the lung, leading to decreased blood flow to the left atrium, low cardiac output, and shock. Sudden death may be the first manifestation if occlusion involves more than 80% of the vascular bed. Findings suggestive for DVT: tenderness, swelling, redness of the lower limb. Unluckily, DVT of the leg is often clinically silent. Differential diagnosis: causes of acute dyspnea with acute chest pain, tension, pneumothorax, pneumonia, bronchial asthma, pericardial effusion, pulmonary embolism, myocardial infarction, and finally acute pulmonary edema or acute heart failure. Investigations: chest x-ray, normal in most cases, elevated copula of diaphragm, pleural effusion, pulmonary infarction, wedge-shaped opacity, dilated pulmonary artery with decreased pulmonary vasculature, Westmark sign. Hypoxia with normal x-ray should raise the possibility of pulmonary embolism. ECG may be normal. We can find sinus tachycardia, atrial fibrillation, S1Q3 T3 pattern, S wave in lead 1, Q wave in lead 2, lead 3, and inverted T wave in lead 3. The most important value of ECG is to exclude myocardial infarction as a cause of dyspnea and chest pain. Echo, enlargement of the right atrium, right ventricle, and pulmonary artery. Pulmonary angiography is the gold standard for making a diagnosis. Spiral CT angiography, less invasive than standard angiography. Ventilation perfusion scan, areas of normal ventilation and hypoperfusion. Lab, arterial blood gases, hypoxia, hypocapnia, elevated serum LDH, D-dimer, end product of fibrin digestion. Good negative test. If it's not elevated, then pulmonary embolism is unlikely. Investigations for diagnosis of DVT, duplex ultrasound, treatment of pulmonary embolism and DVT, prophylaxis, early post-operative ambulation, elastic stocking, elevation of the leg, anticoagulants in high-risk patients for about 1 week, low-dose heparin 5,000 units subcutaneously per 8 to 12 hours, low molecular weight heparin, enoxaparin, Clexane, 20 to 40 milligram per day, curative, hospitalization in the CCU, and we give anticoagulants such as heparin. The mechanism of action: activation of antithrombin 3, 5,000 to 10,000 units IV as loading dose, then 1,000 units per hour infusion, duration for about 1 week or till clinical improvement. Follow-up estimation of PTT should be maintained twice the normal. Antidote: protamine sulfate IV. Low molecular weight heparin 1 mg per kilo subcutaneously each 12 hours. No need for routine anticoagulant monitoring. Oral anticoagulant warfarin. It competes with vitamin K, so it decreases formation of coagulation factors F972. Dose from 2 to 10 mg per day, determined according to the PT. Because of the delayed onset of action, it started 3 days before discontinuation of heparin and continued for at least 3 months or for life in recurrent cases, and it should never be used with pregnancy. Thrombolytic therapy, streptokinase or TPA, indicated in life-threatening massive pulmonary embolism when the patient is hemodynamically unstable, right-sided heart failure or shock. Pulmonary embolectomy, used for those with massive pulmonary embolism when thrombolysis is contraindicated. Symptomatic treatment, analgesia, Picillin, never give morphine. Dyspnea, oxygen inhalation, mechanical ventilation in severe cases. Treatment of complications such as shock and right-sided heart failure. Inferior vena cava filters, greenfield filter, mesh-like filter, placed in the inferior vena cava to trap emboli and prevent them from traveling to the lungs, and it should be considered with anticoagulants and when anticoagulants are contraindicated. Cor pulmonale is right ventricular enlargement with or without failure resulting from pulmonary disease after exclusion of left-sided heart failure and congenital heart diseases. Pulmonary disease leading to pulmonary hypertension, leading to right ventricular enlargement, leading to right-sided heart failure. Etiology: acute cor pulmonale, subacute and chronic. Acute massive pulmonary embolism, acute massive lung collapse, tension pneumothorax. Subacute, recurrent small pulmonary embolization, lymphangitis carcinomatosis of the lung. Chronic cor pulmonale, parenchymal lung disease, COPD, or interstitial pulmonary fibrosis, pulmonary vascular diseases, bilharziasis, or primary pulmonary hypertension, thoracic wall diseases, kyphoscoliosis, I don't know the right pronunciation. Clinical picture of and investigations, treatment of the cause of pulmonary hypertension, of right ventricular enlargement, of right-sided heart failure. Cardiac symptoms, dyspnea. Definition: awareness or difficulty of breathing. Etiology: any left-sided heart disease, lung congestion, left-sided heart failure, mitral stenosis, regurg, aortic stenosis, regurg, myocardial infarction. Chest: all chest diseases, chest wall, obesity, kyphoscoliosis, bronchial COPD, bronchial asthma, pleural, pleurisy, pleural effusion, pulmonary circulation diseases, embolism, hypertension, CNS, increased intracranial tension, leads to stimulation of respiratory center. Abdominal, increased intra-abdominal pressure, ascites, hepatosplenomegaly, pregnancy, metabolic, any acidosis, DKA, lactic acidosis, uremic acidosis. Pathogenesis of cardiac dyspnea: decrease in the level of vital capacity due to increase the amount of blood present in lungs, leading to exaggeration of Herring-Brewer reflex due to rigid alveoli. Churchill-Cope reflex: it occurs in pulmonary congestion, leading to stimulation of respiratory center, fatigue of respiratory muscle due to low cardiac output. Pulmonary edema leads to non-functioning alveoli. Hypoxia, stimulate respiratory center. Pleural and pericardial effusion lead to mechanical compression of the lungs. Grades of dyspnea according to NYHA Association, New York Heart Association. Grade 1, 2, 3, 4. 1 on extraordinary effort. 2 ordinary effort. 3 less than ordinary effort. 4 even at rest. Orthopnea, dyspnea on lying flat, partially relieved by sitting, occurring due to elevation of the diaphragm, increased venous return, which increases lung congestion. No one can blame me when I say orthopnea is not specific to cardiac diseases. It may also occur due to chest or abdominal causes. Paroxysmal nocturnal dyspnea, attacks of dyspnea and cough with frothy expectoration occurring during night, 1 to 2 hours after sleep, and after a few minutes the patient feels better and goes back to sleep. If the condition is associated with chest wheezes, it's called cardiac asthma. Cardiac asthma, state of impending pulmonary edema. And paroxysmal nocturnal dyspnea is a specific symptom to left-sided heart lesion, especially left-sided heart failure. The pathogenesis during sleep are vagal predominance leading to weakness of contraction of left ventricle, absorption of edemal fluid into the circulation, increases venous return, and leads to pulmonary congestion. So we're going to compare between cardiac asthma and bronchial asthma. Cardiac asthma occurs in old age. Duration of the attack is short. Time of the attack 1 to 2 hours after sleep. Low frequency, mainly inspiratory dyspnea. Expectoration is frothy, blood-tinged sputum. Cardiac examination murmurs and gallop. Chest examination crepitations more than rhonchi. Circulation time arm to tongue is prolonged. Morphine leads to improvement. While in bronchial asthma, it occurs in young age. Duration of the attack is long. Time of the attack early morning. Frequency more frequent. Dyspnea expiratory. Expectoration 6 sputum. Cardiac examination normal. Chest examination rhonchi more than crepitation. Circulation time normal. Morphine is contraindicated in bronchial asthma. Hemoptysis in cardiac patient may be due to 7 causes: severe systemic hypertension, ruptured aortic aneurysm, myocardial infarction, Dressler syndrome, post-infarction syndrome, pulmonary infarction, acute pulmonary edema, blood-tinged sputum, chest infection due to lung congestion, and finally pulmonary apoplexy, frank severe hemoptysis occurring mainly in mitral stenosis due to ruptured bronchial varices. Acute pulmonary edema etiology, we have cardiogenic and non-cardiogenic pulmonary edema. Cardiogenic acute left-sided heart failure, myocardial infarction, or on top of chronic left-sided heart failure, mitral stenosis with aggravating factors such as atrial fibrillation. Non-cardiogenic pulmonary edema, acute respiratory distress syndrome ARDS, diffuse alveolar damage, DAD, not your dad, characterized by increased capillary permeability, pulmonary edema, and refractory hypoxia, caused by sepsis, aspiration of gastric contents, 2P, pneumonia, pancreatitis, 2Bs, burn and blood transfusion, terminal renal and hepatic failure. Clinical picture of acute pulmonary edema: sense of impending death, sweating, irritability, severe dyspnea at rest and anosopnia, cyanosis, crepitations, cough with frothy pink sputum, features of the cause myocardial infarction, differential diagnosis of acute dyspnea, myocardial infarction plus the 6Ps as we can find in acute heart failure. Investigations of heart failure, investigations for the cause, arterial blood gases, hypoxia and hypocapnia. Hypercapnia occurs in late cases. Investigations for ARDS, no left-sided heart failure, and we have ejection fraction is normal. Then we have syncope. It means sudden transient loss of consciousness due to cerebral ischemia followed by spontaneous recovery. Causes: vasomotor syncope, orthostatic syncope, cardiac syncope, cerebral syncope, situational syncope. Situational syncope, micturition in old men with benign prostatic hyperplasia. Cough syncope, severe cough, increases intrathoracic pressure, decreasing venous return, decreasing cerebral blood flow leading to syncope. Cerebral syncope, cerebral embolism, hypertensive encephalopathy, transient ischemic attack. Cardiac, exertional aortic stenosis, left-sided heart failure, at rest, congenital complete heart block, ventricular tachycardia, positional, in certain position, left atrial myxoma, acute decrease of venous return, hemorrhage, hypoxia, as in cyanotic spell. Then we have orthostatic syncope, postural hypotension, Addison's disease, antihypertensive drugs, alpha blockers, alpha-methyl dopa, autonomic neuropathy, as in diabetes, weakness of muscles in the lower limbs, vasomotor syncope, carotid sinus syndrome, shaving, carotid sinus massage, vasovagal attack, bad sight, bad smell, exposure to fear. Shock definition: medically, shock is defined as inadequate tissue perfusion. Types and causes: there are 4 types. Hypovolemic shock, this is the most common. Cardiogenic or pump failure due to decreased contractility. Obstructive shock, mechanical obstruction to cardiac output, extrinsic cardiogenic, and distributive shock, systemic vasodilatation, decreasing peripheral vascular resistance. Hypovolemic shock due to volume loss, blood loss, plasma loss, fluid loss, blood loss, hemorrhage, plasma loss, burns, fluid loss, vomiting, diarrhea, dehydration or DKA, diabetic ketoacidosis. Cardiogenic shock, pump failure, extensive myocardial infarction, more than 40% of the left ventricular mass is affected, arrhythmia, acute mitral regurg, obstructive shock, cardiac tamponade, tension pneumothorax, massive pulmonary embolism, distributive shock, septic shock, sepsis with hypotension, anaphylactic shock, hypersensitivity reaction to allergen, neurogenic shock, failure of the nervous system to control diameter of the blood vessels, adrenal insufficiency. Pathophysiology of all types of shock, reduction of tissue perfusion, damage of cellular membranes, leakage of lysosomal enzymes, reduction of cellular energy stores, and finally, cell death. Hemodynamic changes in shock. For the hypovolemic shock, we have decreased cardiac output, decreased central venous pressure, and increased systemic vascular resistance. Cardiogenic shock, decreased cardiac output, increased systemic vascular resistance, and increased central venous pressure. Obstructive shock, we have decreased cardiac output, increased systemic vascular resistance, and increased central venous pressure. Distributive shock, we have in septic shock, increased cardiac output. In neurogenic shock, decreased cardiac output and decreased systemic vascular resistance, decreased central venous pressure. So in all, we have decreased cardiac output except for septic shock. In all, we have increased systemic vascular resistance except in distributive shock because it depends on vasodilatation and distribution of blood to the periphery. Central venous pressure is elevated in cardiogenic and obstructive but reduced in hypovolemic and distributive shock. Tissue perfusion is driven by blood pressure, so blood pressure equals cardiac output times systemic vascular resistance. Cardiac output depends on the venous return, and the central venous pressure is used as an index of venous return. So those variables can be used to describe types of shock, such as cardiac output, central vascular resistance, central venous pressure, and it's measured by pulmonary Castor or Swan-Ganz. And finally, pulmonary capillary wedge pressure, which is equivalent to the central venous pressure, reflection of left atrial pressure by pulmonary Castor as well. Clinical picture, general manifestations common to all types of shock: hypotension, systolic less than 100 mm mercury, mean blood pressure less than 60 mm mercury, tachycardia exceeding 100 beats per minute due to sympathetic stimulation except in neurogenic shock, tachypnea due to metabolic acidosis and pulmonary congestion, oliguria less than 30 milliliters per hour, drowsiness, confusion, cold extremities except in early distributive shock, multiple organ failure. Specific manifestations, we have hypovolemic shock, cardiogenic shock, obstructive shock, distributive shock. For hypovolemic shock, we have same as general manifestations, but clinical picture depends on the volume lost, so it's classified according to the percentage of blood lost into 4 classes, the same as a scoreless tennis game, 50, 30, 40, game over. I'm sorry, I'm not responsible for this. Class 1 up to 15%, class 2 15 to 30, class 3 30 to 40, class 4 more than 40. Cardiogenic shock, same as general manifestations. Clinical picture of the cause: myocardial infarction, chest pain. Clinical manifestations of acute pulmonary edema, dyspnea, crepitations, and congested neck veins. Obstructive shock, same as general manifestations. Clinical picture of the cause: cardiac tamponade, increased jugular venous pressure, decreased blood pressure, and distant heart sounds. Distributive shock: septic shock, anaphylactic shock, neurogenic hypotension with bradycardia. Anaphylactic, warm, flushed extremities, erythema, urticaria, angioedema, bronchospasm. Septic shock, evidence of fever, localized infection, strong pulse, warm, flushed extremities, warm shock. Investigations: lab, CBC, Keftan, lift and tift, lactic acid, blood glucose, blood gases, blood culture. Imaging: X-ray, ECG, echo for cardiac causes of shock, ultrasound and CT for abdominal infections and intraperitoneal hemorrhage. Treatment: the goal is to restore the normal tissue perfusion. General measures: patent airway, oxygen therapy, IV fluid therapy in non-cardiogenic shock patients, Trendelenburg position, legs up, head down, and monitoring of hemodynamics, central venous pressure, cardiac output, and systemic vascular resistance. Specific treatment according to the type of shock: Hypovolemic identifies a source of volume depletion, blood transfusion in cases of bleeding. Cardiogenic shock, treatment of the cause, myocardial infarction, dopamine, dobutamine, mechanical assist devices, intra-aortic balloon counterpulsation. Obstructive shock, relieving the obstruction is life-saving. If cardiac tamponade is present, urgent pericardiocentesis is essential. Tension pneumothorax, treated with needle thoracostomy. Massive pulmonary embolism requires urgent thrombolysis or surgical removal. Anaphylactic shock, adrenaline, hydrocortisone IV, antihistaminic. Septic shock, treatment of infection by antibiotics and vasopressors such as adrenaline. Then we have heart and systemic diseases, neurological disorders and heart diseases, heredofamiliar neuromyopathic disorders, Duchenne myopathy, dilated cardiomyopathy, arrhythmia, sinus tachycardia, ventricular tachycardia, and right bundle branch block. Friedreich's ataxia, hypertrophic cardiomyopathy, more common. Less common, dilated cardiomyopathy, myotonia and muscle dystrophy, myocardial dystrophy, heart failure, arrhythmia and heart block. Cardiovascular abnormality of acute cerebral injury, arrhythmia, cardiopulmonary arrest, myocardial stress injury, catecholamine storm, repolarization abnormalities, depressed ST segment and inverted T wave. Then we have cardiac manifestations of renal failure. We have heart failure, systemic hypertension in 80% of the cases with chronic renal failure, hypertrophic cardiomyopathy, arrhythmia due to electrolytes disturbance, painless pericarditis, accelerated coronary atherosclerosis, cardiac calcification leading to valvular heart diseases, cardiovascular complications during dialysis, heart and endocrine diseases, acromegaly, cardiomegaly, heart failure in 20% of the cases, hypertension in 50% of the cases, atherosclerosis due to hypertension, abnormal lipid and carbohydrate metabolism, thyrotoxicosis in endocrinology book, myxedema, pericardial effusion, hypertension, atherosclerosis due to hypercholesterolemia, ECG changes, sinus bradycardia, low voltage, heart block, Cushing syndrome, hypertension, chronic heart failure, stroke, myocardial infarction, accelerated atherosclerosis due to hyperlipidemia, and finally, we have diabetes mellitus, ischemic heart disease, angina, myocardial infarction. It may be silent and it's higher mortality, hypertension. Causes of hypertension in diabetics, see in the endocrinology, diabetic cardiomyopathy, cardiac autonomic neuropathy, arrhythmia, fixed heart rate, silent myocardial infarction, and postural hypotension. Vascular dysfunction in diabetics, microvascular and macrovascular. Micro, diabetic retinopathy, nephropathy, neuropathy. Macro, atherosclerosis, coronary, cerebral, renal, and peripheral. And this concludes our chapter for today.